Right. Thanks for that. Right. Okay. All right. This is very exciting because we are also not just here on Zoom land, but we're streaming live on YouTube. Okay.
Good evening, everyone. It's Karen Dunkley, just sitting in
on the side, and I'll do it on your computer. Hold on. Go ahead and do it. Hi, I'm trying to. Desiree is having a bit of a phone problem here, so
I see. Okay. Well, we're
I
seeing
will.
it. We're
I'm in
seeing
the
and
room with
hearing
her.
you. Okay. And we're seeing and
So I
hearing
will
you
just
fine.
introduce her and slide over.
Sure.
Give her my computer,
No problem.
and then she'll use her. Then I'll use my phone. I don't want to hold up the. All right. There's my video.
Yeah.
I don't see myself.
We can see you.
Really? So why am I not
Yes.
seeing you? Why am I not seeing you?
Oh, you're not seeing me? I'm in top
No,
corner.
I'm seeing you, but I'm not
Okay.
seeing myself.
I see. That's all right. You look good. So that's the most important thing.
All right, I'm seeing. Okay.
Despite your long day, I know you've had a long day of your meeting and convention.
And you know why I'm looking? Because we're in the room, and I was hoping that all the beds are not being shown.
Okay, that's important bits. And then you have, and you're streaming live on YouTube.
Okay, good. Hi, Joette.
All right. Okay. All right. Well, welcome everyone. I know we want, and this is actually an interesting experiment. I wouldn't say an experiment, but it's the first one of these sessions that we're actually having. And this is something that we want to have for the participants in our live project, which I'll talk about in a few minutes. We're very pleased to be joined with members of the Jamaica Diaspora who are partnering with us this evening and tomorrow as we do some outreach activities within the community. And we hope that this will be the beginning of a number of other sessions like this, where people can have a chance to talk about some health issues. The LIFE project is really a project that we're doing to understand why people develop chronic diseases in Jamaica and even Jamaicans who are living overseas. And so it's important, as one of the things that we ask about are a lot of questions about health and medical conditions. The more that our participants know about these conditions, the better they are able to respond to the many things that we sometimes ask in our questionnaire. So we know we can't begin our meeting without a word of prayer. And we have with us one of our nurses and research assistants, Michelle Garwood, and we're going to ask her to say a prayer for us to begin. Let's see. Oh, where did Nurse Garwood go? Right, and in case we've lost her, you know, we're going to depend on a certain other person that we know. There's a lot of praying for us and our project. So one of our coordinators, Joette. All right, Joette, you can start us off with prayer.
All right, awesome. Let us pray. Heavenly Father, thank you so much for sparing our lives, bringing us together once more in this fashion, this unique fashion, and of course, bringing us here for the first time in this space. Thank you so much for all the different blessings that you have bestowed on us so far. And as we are about to go into this particular session, we ask that you guide each and every one who is about to present, and of course, hasten those who are on their way. In Jesus' name I pray. Amen.
Amen. Mm-hmm. Yes, we have to make the internet faster. All right. Okay. All right. Well, I'm going to just talk a little bit about the Life Project because I know this is being recorded, so some who have come a little late can hear about it at another time. But I'm just going to just share a few facts around it and why it is that we're interested in it, and then we can kind of move into our main presentation for the day. So the Life Project is really an acronym for the word living in full health, and this was something that came up from one of our co-investigators, even though it's not quite fitting, but we felt that it's really all about helping people to maximize their health and their health potential. And the reason why this project is so important is because of what the data you see here coming from Jamaica are showing. And these are data from the most recent national survey, the Jamaica Health and Lifestyle Survey, where it shows the number of people who are obese. And when we say obese, we're looking at persons' weight for height. And then if that number, if you work it out, is more than 30, that means that that person is very overweight. Normal values are under 25. And what you can see here is that starting at a very young age, a large proportion of the population is obese. This is like nearly 40% of women by the time they're in their 30s. Are not as high in men, as you can see in the blue, but much higher in women. And what it means now is that because we have a lot of obesity in our population, obesity is one of the things that increases the risk of so many of our chronic diseases. And these would include things like diabetes, because diabetes is very strongly related to weight. And what you can see here is that as people get older, they're more likely to have diabetes. And women, because they are more obese than men, have a higher risk of diabetes. So you can see women in the red much higher than the men in the blue at every age point. And so by the time people are in their 70s, we're looking at nearly half of the population having diabetes and needing to deal with it. High blood pressure is another common condition. It's really important risk factors for so many other conditions like heart disease, stroke, and what we're finding now, even things like dementia related to blood pressure. And what you can see here is that there's a very high proportion of Jamaicans who have high blood pressure. And so by the time you're getting into the 50s and 60s, nearly 3/4 of the population has this condition. And that's probably why we selected this as the first topic that we want to talk about. Unlike diabetes and obesity, we're not seeing the difference in men and women. The proportion is about the same in both situations. And then when we look at the causes of death in persons more than 5 years, we can find that diabetes and cardiovascular disease and high blood pressure are the leading causes of death in women, in addition to cancer. For men, we see a lot of death from accidents and violence, but after that, we see a lot of stroke, diabetes, heart disease, cancer, particularly prostate cancer. And so these are the things that are actually creating a lot of burden on our society. And that's one of the reasons why we wanted to start the Life study or the Life project, which is a cohort study. So a cohort study is a little different from a lot of the other studies that you're used to. A lot of times we do surveys, just meeting people once and asking them questions, doing their measurements once, and then making assessments about what is going on at that point in time. But cohort studies are a little different. These are follow-up studies. And so it's not just a one-off visit or encounter. We actually want to continue to find out what is happening to people over time, because this is one of the ways in which we can understand the reason why people develop conditions. When we find them before anything is wrong with them, and then we see whether or not their particular habits, lifestyles, or where they live influences their risk of going on to develop some of these conditions. And Jamaica has a lot of chronic conditions, the hypertension, the diabetes, obesity, the cancer. And it's very important that we try to understand what's going on in Jamaica, which is the reason why this is happening. And so the LIFE project's an island-wide study. We're going back to communities that were part of the last lifestyle survey, where you saw some of those data coming from. We're going back to look for those participants who were part of the last national survey. And in addition to that, we're going to persons within each of these communities to find out whether they are also willing to be part of the study, that we can begin to understand what's going on. And we do this by doing a number of things, asking questions about risk factors for chronic diseases, what you eat, your sleeping patterns, smoking, alcohol, your family history. We collect specimens from persons, blood and urine. We've had to hold off on the saliva because of COVID, but hair and nails, because these are things that can tell us over time which persons are likely to develop conditions. And of course, we ask the participants to let us know whether they develop any of the conditions that we're interested in, particularly diabetes, heart disease, and cancer. And so we are always appealing to persons within these communities to join us, because being part of a study helps people to understand their own health. It will help us to understand what's causing so many Jamaicans to have these chronic diseases. It will even help us to find new ways of picking up whether people go on to develop or have cancer, diabetes, or heart disease, and can be very helpful in helping us prevent and treat a number of these conditions. So we have a number of investigators from UWI, Caribbean Institute for Health Research, and you can see them listed here, from Fox Chase Cancer Center, Professor Camille Reagan, and from the City of Hope Cancer Center in California, Professor Kimlin Ashing. And both Prof. Reagan and Ashing are Caribbean nationals who are based in the US, but they have a passion for understanding what's happening in Jamaica and the Caribbean and helping us to improve our health. Those who are in being part of the field team, or who have been meeting some of the members of the team in their encounters in the community, will recognize some of these names. We have two teams now, one that's based in Kingston and the other that's based in Mandeville, and they've been working hard in the communities to engage persons to become part of the study and to help us to understand the chronic disease epidemic that we're facing in Jamaica. And then this is really the last slide, which is just really a picture of the baobab tree. I don't know if you can see, those who have seen the LIFE logo will see that tree in the corner. And really, this is what the tree is based on. So the baobab tree is actually a tree that is seen in Africa. It has actually very deep roots. And one of the things about it is that it can survive even when a lot of things are going wrong, because it has the ability to live despite hardships and difficulties. And we thought that this would be a very symbolic tree for this kind of research that we're doing, to try and understand what's going on in Jamaica and also in the Caribbean by extension, and how we can do our part to help to address some of these health issues. So with those closing or opening remarks, I'm going to stop sharing, and then I'm going to hand you over to our special guests. So one of the things that we've been doing is that we've been partnering, and over the last year, we've had a lot of discussions with our members of the Jamaica Diaspora. Nurse Claudia Powell has been one of the key persons. She's from the Northeast Diaspora Group, and she's been here in Jamaica for the last few days, deliberating with others as part of the Diaspora Conference that has been taking place at the Jamaica Conference Center. And I'm pleased to have her introduce herself and her group of health professionals who have been working with us over the last few months. And then she will also introduce the main speaker for today, who is a member of our team. Miss Dunn. All right, so I hand over to you. All right.
Thank you, Dr. Tuller Reed, or Marshall, but I guess tonight it's Tuller Reed. Anyway, good afternoon, everyone. I'm Claudette Powell, a registered nurse in New York, and we have what's called New York is in the Northeast USA. So we have a sector, the Jamaica Diaspora Health Sector in the Northeast USA. And so it's not an organization, but you have some type of leadership. And I'm the chairperson, and there are members, physicians, nurses, psychotherapists, and other persons who are interested in health. Dr. Camille Reagan is one of our members, and she is the researcher from the Fox in Philadelphia. So Camille introduced us to the LIFE project, and like anything else, we're always looking for initiatives to help Jamaica. And we had some dialogue about it and thought this would be a great time, of course we're not here, that we can help you guys virtually by having instructors, physicians, nurses, therapists work with the registrants. Now, Dr. Tuller Reed, are the persons called registrants or participants?
Participants or volunteers,
patient, right?
Participants and volunteers.
Okay. All right. So the persons who have signed up for the program, they're participants. Okay. So we know that we can work with these participants and help them to manage their condition, non-communicable disease or cancer, whatever the call is. And definitely we will go by your guidance. And so tonight is a night that it's amazing. It's here. I know you have already launched the LIFE project, but this is seen as a launch for the partnership. It's our first time working with the team here in Jamaica. And so for tonight, I have some of the persons on the call. We have Dr. Karen Dunk, are you there? Yes. And
yes, I most certainly am, Claudette. Thank you so much. It took me a while to unmute. Greetings and salutations to everyone. I have to thank you, Claudette. I'm listening and I was trying to read some of the slides. If I could receive a copy of it, I just want to digest the material because I'm coming through the Zoom on my phone. So excited to be here. And just to let everyone know that Claudette, our Jamaica Diaspora Northeast Health Sector Chair, has spoken to us about the launch of the partnership. She's been intentional in the language. So we're excited to be here and to be full partners under the leadership of Ms. Claudette Powell. Thank you.
Thank you, Dr. Dunkley. So we all might be in some place, we just left the conference. We're in our hotel room, so might be on the road. We have Dr. Rosemary
And I am still
Lewis.
at Michael, Claudette. I'm still at Michael.
You're at Michael. Say hi to Michael. He's in the background. Yes. Dr. Rosemary Lewis is a nurse practitioner. She's also at her hotel, and she will be doing a class tomorrow on diabetes. Dr. Lewis, are you there?
Yes. Good night, everyone.
Okay. All right. And there might anyone else from New York? There might Teresa Dunbar. Teresa, she's also a nurse. All righty. Are you there, Teresa? Can't unmute, please.
Hi, everyone. It's a pleasure being here tonight, and I'm excited about this project. So thanks for providing this information. And as being a part of the diaspora, we're here to help. So I'm happy to be here.
Okay, thank you. So do you want me to introduce the speaker now, Dr. Tuller Reed? Yes.
Yes, please.
Okay. Now, Desiree Dunn, everyone who was introduced, most of us are from the Northeast, except for Dr. Rosemary Lewis, who is from Florida. And our speaker tonight is from Chicago. So Dr. Desiree Dunn is a nursing professor and a certified nurse educator with specialization in curriculum development. Former nurse clinician with 12 years experience in medical surgical nursing and 8 years in the emergency department with experience in developing training manuals and programs for hospital nursing staff. So please join me in welcoming Desiree. She will be speaking to you under my name using my computer, and I will try to log on somewhere else. Okay. That's fine. Okay, good evening, everyone. And I'm so very pleased to be a part of this venture here. And it's a bit cumbersome in this little room. And so bear with us, please. You want this, sir? No, I'm good. Okay, so today we're going to be talking about, or I'm going to be talking about hypertension. And the audience is perhaps lay people who don't really understand. Well, who is it that we're going to be speaking to, Dr. Taylor Reid?
Mix of persons. So we have participants, and then you also have other members of the team, of the project team, who have joined us online as well.
Okay, very well. So hypertension is what we're going to speak about, and there are alternative names referred to as high blood pressure, or you may hear it referred to as HTN. All right, and so a little overview of hypertension. Hypertension is the term used to describe the high blood pressure. And high blood pressure readings are measured in millimeters of mercury and usually given in two numbers. For example, 120/80 and written as 120/80 mmHg. So hypertension untreated could lead to stroke and damaged blood vessels, and even heart attack and heart failure. In the United States, 50% of adults are 60% white, 50% of adults, and 60% of those with hypertension are whites, and 70% of those with hypertension are African Americans, 61% Mexican, and some of them are over the age of 6. Most of them are over the age of 60. In Jamaica, I think the latest data we have is that 1 in 3 Jamaicans are hypertensive, and about 36% are women, and 32% are men. And 4 out of every 10 Jamaicans with hypertension are unaware of their status. And the highest prevalence of hypertension is between the ages of 50 to 76. So what is this high blood pressure? So high blood pressure, it's blood pressure that stays elevated. And both readings are important. The top number is considered is called the diastolic, is called systolic, and then the bottom number is called diastolic. So if your blood pressure is 130/80, 130/80 is considered normal if you already have diabetes, mild kidney disease, or heart disease. And how do you know you have high blood pressure? So you have to have your blood pressure checked every year, and the blood pressure varies throughout the day, and you have to have at least 3 different readings on different days. And so your doctor will determine. So normal blood pressure is less than 120/80. No, less than 120. Less than 120 over less than 180. That would be normal. And stage 1, there's stage 1, and then there's stage 2, and then a person can also be in hypertensive crisis. Stage 1 would be 130 to 139 over 80 to 90. So stage 1, 130 to 139 over 80 to 90. And stage 2 would be 140 or more over 90 or more. And if a person is in hypertensive crisis, it would be 180 or more over 120 or more. And remember, the top number is is called systolic, and the bottom number is called diastolic. So then what are the blood, how do we get this measurement though? The blood pressure measurements, it's as a result of the force of blood that's produced by the heart and the size and condition of the arteries. So let's talk about the risk factors. What puts a person at risk? That would be age, ethnicity, family history, genetic factors, and socioeconomic conditions, weight, low physical activity, tobacco use, psychosocial stressors, sleep apnea, dietary factors such as dietary fats, high sodium intake, low potassium intake, and excessive alcohol intake. All right, and some of the causes would be how much water and salt you have in your body, and the condition of your kidneys, nervous system and blood vessels, the condition of your nervous system and blood vessels, and the levels of different body hormones and anxiety and stress. Those are some of the causes. Then there are other causes like cocaine use, and then the person with high blood pressure may continue to be asymptomatic, means that they have no symptoms. All right, so other causes would be diabetes, kidney failure, renal arteries, problems with the renal arteries like stenosis, and sometimes Cushing syndromes. And other causes would be renal vascular obstruction or narrowing, and certain medications and appetite suppressants. Certain cold medicines and corticosteroids also are causes. And obesity as well is one that we should not overlook. All right, so some symptoms of high blood pressure or hypertension is referred to as a silent killer. And it's referred to as silent killer because usually there is no symptoms until it reaches an advanced state. And then once that happens, there'll be chest pain, confusion, buzzing in the ears, irregular heartbeat, nosebleed, some tiredness, and vision changes as well. Could be some symptoms once you start feeling symptoms. So there are tests and diagnoses that your doctor may order. And what was your, doctor wants to know what was your most recent blood pressure reading, and what was the previous blood pressure reading, and what's the average systolic, that's the top number, and the diastolic reading, which is the bottom number. All right, and then your doctor may have your blood pressure, wants to know if your blood pressure has been increasing recently. So they're not just going to be going by one reading, it's at least 3 readings of high numbers. They'll also order electrocardiogram and urinalysis and ultrasounds of the kidneys as well. And some of the, depending on how severe they think it might be, or sometimes in the first stage, when they first recognize that a person has hypertension, they would probably order some of those tests. Then the treatments, some of the treatments, you'll hear the doctor refer to something called beta blockers. And I'm not sure what the beta blockers are in Jamaica. I think they use the Bovalar, I think, and atenolol, bisoprolol.
Yeah, bisoprolol
Is that
and
so?
atenolol. Yeah, those are popular ones.
Right. And then they may use some ACE inhibitors as well. And calcium channel blockers. I think they'd use the nicardipine here and amlodipine.
Right.
Yeah. And some of the diuretics, there's a common one that they use here. I forgot what that's called.
Hydrochlorothiazide.
Yeah, and then there's
indapamide is a common one we have.
Yeah.
I know Lasix is sometimes an overkill, but you know that, yeah.
Yeah. Okay, so those are some of the medications that the doctor may order depending on the person's condition. So then there are also complications now. So you could have blood vessel damage, brain damage even, congestive heart failure, kidney damage, and thickening and stiffening of the medium and small blood vessels. Those could also be complications. Other complications would be kidney failure, heart attack, hypertensive heart disease, and stroke, and also vision loss. So some of these complications may not come on until it gets bad. And so there will probably be no symptoms until you start experiencing some of these complications. So what are the blood pressure goals then? So the goals would be in line with whatever condition the person has, like a person with diabetes, they may, their normal the doctor might try to maintain their normal a little bit higher than 120/80, maybe 130/80. And it depends on which source you are looking at and which doctor is managing which patient. Each patient is quite different. So when do you contact your doctor if you are having any of these problems? So you should call your healthcare provider right away. If home monitoring shows that your blood pressure is high, or if you have any of these symptoms, chest pain, confusion, ear, nose, or buzzing, ear or nose buzzing, irregular heartbeat, nosebleeds, and tiredness, and vision changes. So what's the prognosis with this? Most of the time, high blood pressure can be controlled with medication and lifestyle changes. And so that is what we are aiming at, especially dealing with the patients who come to the clinics all the time. So treatment goals would be, goal of therapy would be lifestyle modification, pharmacological treatment. So the doctor may prescribe some medications or something like that. And then they have to be following up with the doctor and having this monitored. So that's really the goal of treatment, is keep the blood pressure within normal. And like I said, the beta blockers would be a mandatory part of the therapy for heart failure due to systolic dysfunction, which is and they can use a combination of diuretics, which is the Lasix, in combination with the beta blockers or the calcium channel blockers as well. Okay, and then most patients need at least 2 medications. So you may be prescribed at least 2 medications to achieve the targeted blood glucose level, blood pressure levels as the doctor sees fit for your condition. So when we talk about lifestyle modification, what do we mean? So you should lose weight if you're overweight, limit alcohol intake if you drink alcohol, and reduce the sodium intake to less than 2 to 3 grams a day, and maintain adequate dietary potassium, calcium, and magnesium intake. And so when you buy things like the sugary drinks, let me see this one. So these drinks, I know that the Ministry of Health is trying to push this message. And I'm looking at this tropical rhythm drink, which has 47 grams of sugar and other things that so get in the habit of reading labels, okay? And then you can get some instructions from your doctor as in terms of what he wants, how he wants to manage your blood pressure. Okay, and perform aerobic physical activities for at least 30 minutes a day. Eat diets that is rich in fruit and vegetable, low-fat dairy products. Reduce saturated fat and cholesterol, read your labels, and stop smoking. Smoking is just bad for everything. And follow healthy eating plan. So with the fruits and vegetables, low-fat dairy products, include whole grains in your meals, low-fat poultry, fish, and nuts, and eat less red meat, and drink lots of water if it's indicated. Limit your sodium and salt intake. So you lower the salt intake by eating out less often. Kentucky Fried Chicken is full of sodium. Eat less canned foods. Use less salt when cooking, and be aware of processed foods. And I tell you, if you start using less salt and less sugar, you'll just get used to eating that way. And anything with a lot of salt will be very disgusting to you if you just start doing it. And so lose weight if you're overweight. Heavier people need more blood to supply nutrients to the body. And losing even 10 pounds can lower your blood pressure. And check with your doctor before you go on any exercise regimen. Yeah, so physical activity, inactivity will increase the risk of overweight, and heart muscles have to work harder and with increased force against the arteries and damage your heart vessels. And then walk at least 30 consecutive minutes per day. That would be good in terms of physical activity. And what else you need to do? Stop smoking. Smoking, it damages the walls of the blood vessels and cause early hardening of your arteries. And the nicotine, it narrows blood vessels and causes the heart to work harder. All right, limit alcohol. Heavy drinking, like 3 or more drinks per day, can damage heart muscle. And cutting back on that can lower your blood pressure. Okay. And manage stress. High levels of stress can cause dramatic increase in the blood pressure, and to develop some kind of relaxation technique to deal with your stress. Okay. And what are some things to remember here? Lifestyle changes. It can prevent and control blood pressure. So eat more fruits and vegetables, low-fat dairy products, prepare meals with less salt, lose weight if you're overweight, increase the physical activity, and drink in moderation if you do drink alcohol beverages. Okay, and that's basically all I have. And exercise, maintenance of healthy weight, healthy diet, low salt diet, rich in natural sources of vitamins and minerals. There's plenty of that here in Jamaica. Everywhere you go, you see lots of fruit stand, vegetable stand, and these are things that are good for us, but yet we run to Kentucky, and that is really not good for us. Okay, and so that's all I have.
Yes. So thanks very much, Dr. Dunn. Thank you for that overview of hypertension, very detailed and had a lot of facts. I know that we are going to have, if anyone has any questions, they can kind of put them in the chat. I'm going to ask Janelle to let me know if there are any questions that are popping up on the in the chat. But I think I have a couple of things that maybe we can talk about when it relates to high blood pressure in Jamaica. So I know you mentioned the numbers for America, but what we're seeing from our last survey is that we're looking at nearly 3/4 of adults in their 40s in Jamaica having high blood pressure. And I guess, we're just not sure why it is so common and why people kind of, may not recognize the importance of this health condition, because it does create a lot of problems. I was just in Mandeville a couple of weeks ago, and when I was there, I met with the doctor at the hospital, and they said that so many of the patients that they were seeing in the medical clinic were patients who had developed kidney failure because the high blood pressure had been out of control for so long. One of the issues may sometimes be people not recognizing how important it is to manage high blood pressure. And I know that in the US, there are a lot of issues around awareness and so on in the Black or non Caucasian populations. I'm not sure what your experience has been, just from working there and so the challenges that you have seen there, because those may be similar challenges to what we're experiencing now.
Yeah, we see similar things there, and a big problem we have is access to care. And so they wait until it gets too bad before they come, and then when they go to the emergency room. And so they don't have regular physicians that they go to do checkups and so on. Yeah,
and that's a very critical part of the high blood pressure management, because just going in when you feel sick or going from doctor to doctor is not helpful, because you start with one medication and then nobody knows whether it works before you add something else, and then you just kind of have this this person gives you that and that person gives you that, and then the continuity, that continued monitoring to say, okay, well, you're put on this medicine. How are you doing with it? Are you having any side effects? Is it your blood pressure where it should be? That's an important element of care.
Yeah, and I remember when was that? 2015. We were here with a medical missionary. We went up to Hanover. With Dr. Street's clinic, and there were people there who came with prescription for blood pressure medications, who were given these prescription when the mission was there the last time, the year before, and it still was not filled. And so you kind of wonder, and sometimes I wonder where the priority is too, because my goodness, if you see how they dress nicely, and then their prescription is still not filled. And even if they're getting these things from abroad, they could probably ask for a little money to fill the prescription instead. So, you know.
Yes, I mean that, and that's a trick about high blood pressure, because you feel all right, and I think people, once they feel okay, they believe everything is okay, and so you don't recognize what is happening at the same time. One of the things that I've seen a lot of emphasis being placed on is measuring blood pressure at home. And I don't know if that may be something that may convince people of what's going on. I'm not sure what your experience has been with people doing their own blood pressure measurements at home and just monitoring themselves.
Yeah, and another thing with that too is that they don't know the correct way to do it. And so someone may just have bought them a machine, and they're not sure how to put the cuff on, or if they're using the right cuff or placing at the right place. So a lot of education needs to be placed on that too, monitoring. And self-management is just a big thing.
Because I'm not sure if people see the numbers, because you're feeling all right, the readings can be quite high, but maybe sometimes if you're checking and you're seeing, okay, the numbers aren't really that great here. So maybe something needs to change. And you spoke about the numbers. I mean, for us in Jamaica, the current Ministry of Health guidelines do recommend that persons with high blood pressure try to keep their systolic or top number under 140 and their diastolic under 90. That's generally for most people. But of course, there are people who may have special conditions. You mentioned diabetes, or people whose kidneys are not 100%. And so therefore it's more important to get the blood pressure down, or heart disease. And their target is usually 130/80. But I noticed that generally everybody is trying to get blood pressure lower. So even though we talk about, the 140/90, they're saying that's not good enough.
Right. My doctor says 120/80.
Yes, well, I mean,
So
that is the
he wants
latest.
to keep us 120/80.
Yes, that is the latest thing, because I know you had a very big study of high blood pressure, even in people who are elderly. And we didn't have diabetes, and they were saying that 120/80, and we've been happy with people getting blood pressures of 160 or 50, but they're saying right down. It's an interesting number, because a lot of people still believe that 120/80 is normal, but 120/80 is already high. Based on the latest
that's right.
things.
It's supposed to be less than 120/80.
Less than 120 and less than 80. So when people go and they say, oh, my pressure is low, it's 90 something over 60, and then they're saying, must I eat salt? You have to say, no. Normal is under 120 and under 80 is normal. Once you're touching the 120 and touching the 80, you're on your way to high blood pressure. Yes.
Another thing we probably should mention is the medications.
Yes.
Like when a person get diagnosed with hypertension and they are given these or prescribed these medications, and they may have some side effects and they stop taking it.
Yeah.
And so that is very important to report back to your doctor.
Right.
If you are prescribed something, especially for the first time, and you're having problems with it, that's why he wants you to follow up. And they don't find that they don't really follow up, but they take it once or twice. They may have some problems, but they also feel better.
Yes.
And then they stop taking it.
And that is a danger, because I think I know a lot of Jamaicans don't like to remain on medications. They don't want to be dependent. I know that's a term I've heard a lot of people talking about, that they don't want to become dependent on the medications, and that they prefer natural methods, or want to wean off. But just I always have to have the discussion, and it's really about making sure that you're hitting certain goals. So if you're able to get those goals without medications and with your lifestyle changes, that's fine. But if you're not hitting those goals, you do need to get some help. And these things can work in combination. So it doesn't have to be one or the other. Just the same way we talk about lifestyle, your exercise and not smoking and avoiding a lot of salty foods or processed foods, trying to eat things that are more natural, their fruits and especially the vegetables, which we know a lot of Jamaicans don't seem to take a lot of those in. Those are all things that can help to complement the tablets and maybe even prevent you from having to take as many or as high a dose, because they all work together to get you safe.
Correct.
Yes. So I mean, those are a lot of interesting things. We're actually just trying to understand a couple of things as well. I don't know if you would mind if I shared a slide. I'm going to share a slide just from some data that we have, and I want to ask you one question about it because of what we're seeing here. And I don't know if you have your you can put on your analytical hat. These are just some data. This is actually something from our 2007 survey. And actually what we looked at in these data were just about how many people in Jamaica had hypertension, and then looking at all the things that would actually allow them to get to their special blood pressure goal. And from that survey, about a quarter of the population had hypertension. I mean, if you look at people 15 to 74, of that number, maybe about half of them knew that they had high blood pressure. And so your point about having your blood pressure measured becomes very important. One of the things that we did find was that once people were told that they had high blood pressure, they did actually come in for care. And so most of the people, if you look at the numbers, almost everybody who was found to have hypertension had said that they went to the doctor for their blood pressure, but they were not as many of them were continuing to keep their appointments, and that's disappointing. And then of those who were going for their care, a smaller number of them were on their blood pressure tablets. So that's something that we spoke about. And then when we looked at the number that were getting their blood pressure to 140/90, which is Jamaica standard, only a small proportion, like 74,000. So if you look at nearly 500,000 Jamaicans with high blood pressure, and only less than a fifth of them actually have blood pressure under control, you can see why we would have so many complications taking place. But these were the other thing, which is just a breakdown of some of that data. And we looked at it for men and women. And I think one of the big things that we're seeing is that the men are not told or aware. So even though the number of men and women with high blood pressure is the same, the men are not being diagnosed to the same extent, and less of them are likely to come into the doctors for care or stay in care or be on their blood pressure medications or have their blood pressure control compared to women. So at every point, apart from having high blood pressure, there are fewer men getting to those targets. And I don't know if this is something that you have seen, and if you have any suggestions around things that can be done to encourage men to become more active in terms of taking care of their blood pressure and doing some of the things that help to get them to goal.
Yeah, I don't know. It's something that I've seen in my practice as well, in terms of even other health conditions. I can remember working with urology patients, and almost all the Jamaican men that came there and have problems, like with prostate cancer, stuff like that, they never went to the doctor for checkup. And a lot of times they come in and it's gone too bad, already spread. So, and we're saying, I mean, didn't you feel different in your body? But they just have, I think the men just kind of have this macho kind of thing about them, that they can handle it, or they can do it, or something like that. And then the population of people in the lower socioeconomic conditions, we living in the lower socioeconomic conditions, they are the ones that, they really don't seek help until they are the ambulance has to come to the house to get them or something.
Yeah,
and then
yeah.
a lot of times it's too late. And then I'm curious as to where in Jamaica these numbers were taken. I might have said it on the slide and I didn't see it.
Yeah,
You know,
these are from these are from the survey, the island-wide survey done in 2007. So these are not just, you know, one part. It's and hospital people. These are just going into the communities and seeing what's going on.
Okay. Yeah, and I don't know. The people that live in the country, they tend to be more focused on the herbal medicine, the what do you call it? Bush medicine?
Natural, right? Natural, right? Yes.
So you want to take a bush for this and a bush for that, and there's something for everything. And I mean, I'm not saying there's no truth to this, but we have to have scientific proof of these things.
Very important.
But they swear by it, and then you know, they'd rather do that than seek medical help.
Yes. All right. Well, it's a few minutes to 8, and we're trying to keep to time so that this will be the first of many. So those who don't get a chance to ask questions, I'm sure we'll have another opportunity. And I'm glad that this is going on YouTube so that it can be recorded, and that we will also have it probably on our website, that participants can take a look at another time. Nurse Claudette, you look like you have a burning point.
I just wanted I want to make a comment about the men.
Yes.
When I go on even in New York on these community health fairs, I mean, it's a challenge working with them. But I'm making a suggestion: if these men stop by with a female partner, work with the partner too. Get these women to really talk to the men. That can work too. You know, tell them, I mean, if you stroke out, you know, especially if they're Jamaican, then you start talk to them like you know them.
Yes.
You could say, boy, if you stroke out, you know, really, that the woman can tell them that. I don't have, that's it, I'm going to somebody else.
And they're concerned about a certain side effect from the tablets, and they don't realize that will happen when the blood pressure is not managed.
Then when it comes to that part, I know someone who said she told her husband, because his father died at age 40 something. And her husband had severe hypertension. And sometimes a woman has to also make the man know it's okay if that side effect should occur. But when I do the teaching, I'll tell them it doesn't necessarily mean that you have to, if it happens, you go to the doctor. There are other medications that they can try. But the partner can say, if there's nothing else, I'd rather have a husband than, you know, something like that. The women have to make these men feel that it's okay to get, that's priority. That's a suggestion. Yeah, but we get it all the time. Black men, it's a problem.
Yes. Oh boy. Well, this has been a very informative session. I'm glad we had this discussion. I think the takeaway points, of course, are for people to get their blood pressure measured. You know, if you're part of the LIFE project, we will do that, because that's an opportunity that we provide for you, because a lot of people with high blood pressure don't know they have it. And then, of course, knowing what your numbers should be, that's very important, because, you know, it's one thing to see the numbers, but, you know, what should my number be? If I'm not if I don't have high blood pressure, my number should be under 120. If my top number, my bottom number, my diastolic should be under 80. So that would tell me that I'm okay. But if I'm seeing it creeping above that, I know I need to be careful and do some things to try and get it back to where it should be. Losing weight, being active, cutting back on the salt, having my vegetables with meals or my fruits in the right proportions. That is important to help to keep the blood pressure down, managing stress as best as we can, you know, making sure you have time for your friends and other things that can help to relax you if you feel that is becoming overwhelmed. And then, of course, if you do have high blood pressure, that regular monitoring with your doctor is important. In addition to all the lifestyle things we spoke about, that monitoring to make sure your blood pressure is checked, If you have your own machine, that's nice because you can check it at home. Because, sometimes when you go to the doctor's office, it's nerve-wracking, or by the time you fight with the people to get in there, the pressure goes up. But you can't talk about that when you're at your home, relaxing with your water. You can check your blood pressure and know what it is. And I'm sure we'll have a chance to talk about how they should do their blood pressures and so on. But that would be very helpful, that monitoring and talking with your doctor just about, how the medication should work, if you're having any side effects and so on, because you do want to take your medicines consistently, not just one-off or when you feel ill or when the pressure is high, because that's really what helps to make the difference and keeps you from getting those strokes and heart attacks and kidney problems and dementia, which is becoming so common in Jamaica now. And even that other complication that people are worried about from the medications. It helps to prevent that too. So all good takeaway points that we can leave here with. So thanks everyone. Thanks Diaspora.
Yes.
Thanks Live Project team. Thanks for joining us. Thanks to the technical team who helped set up and put us on YouTube. I don't know where we're broadcasting to, but whatever I've said, I hope it can stand the test of time.
Yes,
right.
okay.
And then we will continue with our outreach tomorrow. So I look forward to seeing you in person and meeting with the other members of the team. So for all who joined tonight, have a good evening and
good evening.
Take care. All right.
All right.
All the best.
Thank you.
Thank you.
Yes, thank you.
Bye. All right. Thanks.
Okay.
I don't know when I'm going to stop broadcasting to YouTube, so try to be careful. I'm going to log off.
All right.
See you tomorrow.
Okay. Right.
Yeah. All right. Have a good evening now.
Yes, you too.
Take care. Bye.